This is how I treat lupus in 2019, but we're also going to talk about how you will treat it in 2020, or at least have some choices in treating it in 2020. So same potential conflicts of interest. Now I've actually said that I have no major stock holdings in everything. It's becoming apparent. Okay, so this is the case, one case. A 30-year-old African-American stock analyst has a 6-month history of malar rash, arthralgias, arthritis in her hand joints, and recent pedal edema. She's evaluated and found to have a high double-stranded anti-DNA antibody, a low complement. Her urinalysis has 3+ proteinuria, 2+ hematuria, and her creatinine is 1.3 milligrams per deciliter. Her diagnosis is lupus. They think she has lupus nephritis that's active clinically. Her biopsy shows diffuse proliferative lupus nephritis with extensive mesangial and subendothelial immune deposits. So these are the questions we'd like to answer, and these are the questions that you probably will be having. I mean, that's what people are asking me in the back of the room. What induction therapy would you use? Does the fact that she's African American, a minority, influence your therapy? What if she had a serum creatinine of 3.5, or if her biopsy had extensive presence or tubulointerstitial fibrosis? What if her biopsy was membranous? What is the maintenance therapy for this patient, and how long would you use the maintenance therapy? And if she relapses or becomes resistant, what are your therapeutic options in 2019 and where they may be in 2020? So the first question is easy in terms of how to treat this patient, because we have 2 very well accepted induction therapies, and some variations on it, but essentially you could treat this patient with mycophenolate and steroids for 6 months, or you could treat this person with cyclophosphamide and steroids for 6 months. And you might use pulses of methylprednisolone with the steroids, you might not. You might use the Euro-Lupus regimen, which we'll talk about, or you might use the older NIH regimen. And there are people who also use oral cyclophosphamide. So there are some different options here, but again, you're talking about 6 months worth of induction therapy here. Now, where did this come from? Well, the mycophenolate started with a study that I always call the Ginsler study. Ellen Ginsler, a rheumatologist at downstate New York, put this study together and pushed it all the way through. That it looked at 140 patients, which included a lot of minority patients in our area, and compared mycophenolate to the older regimen, the NIH regimen of monthly IV cyclophosphamide, 0.5 to 1 gram per meter squared, given every month for 6 months. So complete remissions actually turned out to be higher with mycophenolate. Partial remissions were the same, complete and partial were higher, given that it suggested that mycophenolate had a role. Now, there were a number of problems with that study. One, the rheumatologists had never at that time used mycophenolate. They didn't want to leave their patients on mycophenolate if it was failing. So at 3 months, if you were doing badly, you could roll over to the other arm of the study. Well, that caused some conflict. Secondly, the study was done at 18 centers, all in the US. There is no study center outside of the US. It's a very international community now. So there are clearly some problems in design of that study. We were actually the last center to join. We were the only nephrology center involved in that, and we joined it because we thought it was a good idea, but didn't like the study design and had no say over it. This was followed, therefore, by the ALMS trial. The ALMS trial looked at 370 patients, so a much larger study. International study, a third of the patients are in the US, a third of the patients were in China, and a third of the patients were in Europe or South America. You were randomized to MMF or IV cyclophosphamide. Now you had to stay on that regimen for 6 months. If you were failing, you were out of the study. You couldn't randomize over to the other arm. And the group was analyzed at 6 months. Now, there was a maintenance phase, which I'll talk about later, for those people who were doing okay at the end of 6 months. But nevertheless, we had a large enough study sample here to look at details. When we look now at the response rate, they were identical. Mycophenolate was not superior to IV cyclophosphamide, but it was equivalent to IV cyclophosphamide. Many people, in fact, most people feel mycophenolate's a more benign drug than an alkylating agent. So this was a win-win for the mycophenolate arm. And again, not that it was superior, but again, equivalent to the older NIH regimen. Now, at the same time, the Euro-Lupus trials were going on. The Euro-Lupus trials, which Fred Husio ran out of Belgium, but again, a collaborative European group, first looked at 90 patients with proliferative lupus nephritis. They were followed for 3.5 years with a subsequent much longer follow. They either got what they called high-dose IV cyclophosphamide. This was the standard dose at the time used by the NIH for years, 0.5 to 1 gram per meter squared, given monthly with high-dose steroids that was tapered, or low-dose IV cyclophosphamide. This is 500 milligrams given intravenously every 2 weeks, but only for 6 doses, 3 months. That's it, then you stop, and this is then followed by oral azathioprine. And again, I think most people in this room would agree that azathioprine is a much more benign drug in terms of side effects than cyclophosphamide. So they did this trial, and here is the 10-year follow-up now. If you look at free of renal failure, the regimens are identical, whether you use high dose or low dose. If you look at the end of 10 years, the serum creatinine, one for the whole group, one for the low dose and the high dose group. If you look at proteinuria, about the same. The biggest difference was if you look at the cumulative IV cyclophosphamide dose, it was 9.5 grams in the high dose. It was 5.5 grams in the low dose. So again, if this were your wife or your daughter, you would say, my goodness, I would much prefer them to have a low dose of an alkylating agent than a high dose, especially since they're coming out with the same outcome over time. Now, this patient happened to be, I made this stock analyst African American. So what is the data in African Americans? If you're not from the United States and you say, well, we don't have any African Americans, we may have people of Africa, but we don't have African Americans. But this is true for a lot of minority groups that they've done worse. In the United States, we think this is both biologic and also in terms of sociologic factors, in terms of income and things like that. But it's partially biologic as well. In any case, if you look at African Americans here from this study in UNC, they have a lower renal survival at University of North Carolina than did non-blacks. If you look at a study we did on 129 patients looking at, again, focal or diffuse proliferative, this is the renal survival here in the whites. Here are blacks and Hispanics. And a third trial from University of Miami, from Gabe Contreras' group, here are the Caucasians over 5 to 6 years. Here are the Hispanics, and here are the African Americans doing worse. So regardless of what reason they're doing worse, some of the studies should take into account exactly how do African Americans do compared to others, and how do they do in these different studies. Now, that's one of the reasons in the mycophenolate studies originally, we purposely tried to recruit a large number of minorities to show that that drug would work. But what about the Euro-Lupus data? The Euro-Lupus data, by definition, is Euro-Lupus. It's including countries like Belgium, the Netherlands, Spain, countries where, again, the population is largely white. Can you apply the Euro-Lupus data to the stock analyst? So the answer is probably yes. Now, I say probably because the numbers are relatively small, but there is a trial that went on with abatacept. We'll talk about abatacept later. This is a co-stimulatory blocker. But in the ACCESS trial, everybody got the Euro-Lupus regimen of low-dose cyclophosphamide. That is, they were getting a dose of cyclophosphamide every 2 weeks for 6 months, 500 milligrams every 2 weeks for 6 months, and steroids that, and then followed with azathioprine. So half of the group got abatacept added onto this regimen. Half got placebo added onto the regimen. If you look at all patients, all others, and African Americans, they did the same, regardless of which group you were in. Now, what does that say? Well, it says, one, abatacept didn't do very well in this study, and of course, that's one of the conclusions. However, it does say that the low-dose urolupus cyclophosphamide regimen worked well in what they called a diverse North American population, which included African Americans. Now, if there had been 500 patients in this study, I could conclusively say this works, but nevertheless, it is likely to be effective, and at least there are data in African Americans saying that both of these regimens could be a first-line regimen in your patient. Now, a word about classification. So we started off with the most simple classification where we had 6 classes of lupus: class 1 minimal, class 2 mesangial, class 3 focal proliferative, class 4 diffuse, class 5 membranous, and class 6 advanced sclerosing. Then over time, by reanalysis and pathologists and clinicians getting together, we got to the ISN-RPS classification. Much more complicated. Not that complicated for a nephrologist, but I can tell you, if you show this to the rheumatologists, I mean, they'd rather, read the kidney biopsy themselves and look at all these things here. And this had a couple of things that were different in it. One, it had the A and the AC and the C. A for active, AC for active and chronic, C for chronic. That it also divided the diffuse proliferative into those which had segmental lesions and those which had global lesions in the individual glomeruli. So you end up with a diffuse proliferative group that's very diverse here. You're talking about segmental active, global active, et cetera, et cetera. Very confusing. Anyway, needless to say, when we get this confusion, we actually, or you can look at it the other way, you finally learn this classification, they want to change it again. So there is a revision of this. And the revision is late 2018, so it's less than a year old. This is, again, the ISN, the Renal Pathology Society. Here are the changes. They eliminated the S and the G. Well, that's good because a lot of people didn't pay a lot of attention to it. So at least now that's eliminated because there was a lack of evidence that it made a difference. Okay. They defined mesangial hypercellularity as over 4 cells together. Well, that's not going to affect anybody because you just read what the pathologist says. If Helmut says there's mesangial hypercellularity, so okay, you accept it. You don't have to ask him, well, how many cells were there? Endocapillary proliferation is now replaced by hypercellularity. That also doesn't change your interpretation of how you're going to treat the biopsy. I mean, in fact, only a pathologist would care if you said proliferation or hypercellularity. They do want to change the A and C back to the modified NIH Activity and Chronicity Index. This will make a difference because it took a little while to get everybody to accept A and C, and now we're telling the rheumatologists who are dealing with us, now we're changing the whole story here. So I like A and C, I like the Activity and Chronicity Index, but in any case, I'm going to tell you how I look at the kidney biopsy, okay? So I've made it down to only 5 points. There are only 5 things that I'm really concerned about in the biopsy because essentially I'm like most of you. I have to treat the patient. I don't have to worry about how many cells are mesangial hypercellularity. So first of all, when you look at the biopsy report, is the biopsy adequate? The very first thing they're going to say is how many glomeruli there are. If there are less than 7 glomeruli, you're making guesses as to what's going on. Now, there may only be 5 in the light, and then they cut it wrong and everything's in the IF and EM, and you can make some judgments on that. But still, if you have less than 7 glomeruli, it's a total guess. Focal, diffuse, proliferative, one more one way or another would change it. The ISN class only treat vigorously focal and diffuse proliferative if they're active. Active being A or AC, but not chronic. Now, you can use the activity and the chronicity index. If your activity index is high, if your chronicity index is high, that tells you active or chronic. But again, they've got to have some activity if you're going to treat them with some of the therapies we're going to talk about, and also treating them with mycophenolate or IV cyclophosphamide. So again, some of those membranous and diffuse and focal patients will get vigorous treatment. Third, the more chronicity, especially interstitial fibrosis, the less the benefits of treatment. Glomerular sclerosis, you can have 90% of the glomeruli scarred, and that somehow those patients go on for a number of years. I mean, like it may be a sampling error or whatever, but if you have 90% interstitial fibrosis, that would have to be a terrible thing. You would have had to hit a scar on whatever sampling you did entirely, because most of those patients are doomed. So tubulointerstitial fibrosis is a bad thing in every glomerular disease, and especially bad lupus nephritis. Number 4, are the deposits extensive? Now for this, I look at the electron microscopy. IF is more sensitive than EM. You'll pick up more on IF, but the EM is a picture. They send you a photograph. You know exactly how many deposits they are and where they are, and you can show them to anybody else. The IF, somebody's in a dark room and says the IF is 3+, 2+, whatever. If they had a bad day, it's 3+. If they had a good day, it's 2+. So, again, it's a good thing Helmut's out of here already. But in any case, the EM is more specific in terms of you can show it to anybody and convince them. And finally, fibrinoid necrosis and crescents. If you have lots of crescents, those are bad. They are potentially treatable. Well, necrosis really isn't treatable, but you can prevent it from spreading. But the crescents, if they're proliferative, they are treatable. But again, those are bad findings. So that's what I look for in a biopsy. And actually, I've had Vivek Tagadi and Glenn Markowitz have said that this is what it comes down to for treatment. Now, what about if this patient had a creatinine of 3.5, or if they had a lot of interstitial fibrosis, or they had a lot of crescents on their biopsy? What would that do? Well, you try to go back and find it. Almost none of the controlled trials will accept any patients like that. There is one interesting sort of mistake that took place in the ARMS trial. Out of the 370 patients, a post hoc analysis found that 29 of the patients should never have been in the study, because it turns out their GFR was too low. Their GFR was less than 30 cc's a minute. Now, how they got in, I have no idea, but, out of 370 patients, that doesn't surprise me, that it's international, and people are using creatinines and everything. Anyway, by chance, those 29 patients, 18 got MMF and 11 were randomized to cyclophosphamide. Baseline, they were similar in age, proteinuria, big league, chronicity on biopsy, and GFR. So you look at these, there was no difference in the composite outcome in terms of proteinuria or serum creatinine. Actually, the GFR increased more in the MMF group than in the cyclophosphamide group. Proteinuria decreased more with MMF here. So at least you could say for a very severe group, in an anecdotal way, that the MMF was certainly no worse than the cyclophosphamide. I wouldn't say it was better based on this, but it certainly was no worse. 25% of both groups had a bad outcome. And I think this goes along with something that John just said that I'm going to emphasize again later in terms of ANCA or any disease. The lower the GFR, and I would add on the older the age, those two things are usually bad finding. Now, this is a young population, but the lower the GFR, the worse they're going to do in terms of adverse events. Anyway, there was no conclusive evidence from this that IV cyclophosphamide was more effective than MMF. So what about maintenance therapy? If you got MMF induction and you improved, you go on to maintenance therapy with either mycophenolate or azathioprine. If you're not improved with MMF, you swing over to the other arm and you get cyclophosphamide by some regimen, either NIH or the Lupus, or some people would use oral, though again, that's a minority. If you got cyclophosphamide induction and you're improved, you either get MMF or azathioprine for maintenance therapy. If you're not improved, then you swing over to the other arm and get MMF. So the first two arms of therapy are pretty clear in this. You have a choice between them. You take one. If it doesn't work, you can always swing over to the other. Now, what's the maintenance data? Where does that come from? So in the ARMS trial, this was an induction and maintenance trial. So of the 370 patients over time, everybody was randomized to MMF or IV cyclophosphamide on the older NIH regimen for 6 months. After 6 months, if they were responding, they got re-randomized to MMF or azathioprine in a double-blind randomized fashion for 3 years. Now, if you asked me how they were going to have done, I would have said they would come out the same. Because again, azathioprine is a pretty good maintenance drug, I think, for lupus. I used to use it all the time. In any case, with 227 patients in the second phase, the maintenance phase, it turns out mycophenolate came out superior to azathioprine. Let's look at some of the details. First of all, percentage of patients with treatment failure. Here's the MMF group, here's the azathioprine group, almost double. End-stage renal disease only in the azathioprine at the end of the 3 years of maintenance follow. Renal flares higher with azathioprine, creatinine doubled higher with azathioprine, rescue immunosuppression needed higher with azathioprine, and some broad FDA definition of doing badly, again, with azathioprine. So in every one of these, the MMF was coming out better. If you look, because you still had 220-something patients in the study, if you looked at racial background, again, here's treatment failures. The MMF was better in whites, in blacks, in Asian, and whatever else is left, and other. If you looked at areas of the world, the MMF was better in the US, better in Latin America, better in Asia, and better in Europe. Notice it was least better, it was better, but least so in Europe. Again, that's a Caucasian population that does very well. Most important, if you got induced with 6 months of mycophenolate and you stayed on mycophenolate, you were randomized to continue it for 3 years, you did better than if you were randomized to get azathioprine. If you randomized initially to get IV cyclophosphamide and then after induction were doing well and got MMF, you did better. You had less treatment failures than if you got azathioprine. So no matter what you looked at in this study, the MMF came out better. Now, some people have said, well, there's the MAINTAIN trial that was done in Europe that the Lupus group did, and that didn't show the same thing. So let's look at the differences. First of all, in the ARMS trial, we had 220-something patients in this trial. If you were doing okay, you got re-randomized. If you were doing badly at the end of the 6 months of induction, you got randomized over to the other arm of induction or whatever, but you could get whatever your doctor wanted. You were not in the maintenance study. In the MAINTAIN trial, they started out with everybody getting their typical regimen for this, which was getting the IV cyclophosphamide, 500 milligrams every 2 weeks for 3 months, and then patients either got mycophenolate or azathioprine. And again, at the beginning, you drew a card. You were going to go into that either way. Now, there are a couple of things about why could they do that? Because as I showed you, everybody did well. There was almost no renal failure when they followed their patients for 10 years. Well, why was that? It's a very different population than a population in China, South America, or in the United States with minorities. A European population, if they're treated, is going to do well in general. The other thing is they couldn't use renal failure. They couldn't use doubling the creatinine end-stage renal disease like we did for treatment failure because almost nobody went to dialysis in 10 years of follow-up. So they used renal flares, the probability of not having a renal flare. Third, there were only about 90-something patients in the study, less than 100 patients in the study. So what happened? There was no significant difference if you follow them out 4 years worth of maintenance therapy. But the number of flares, 25% of the azathioprine group flared, 19% of the mycophenolate. Now that's only 90 patients. If it had been 220 patients, it might have been statistically significant. If they looked at a different population, it might have been statistically significant. So this could be a numbers game here and nothing to do, or a population that you're treating rather than a significant difference between the drugs. So here's my take on this. I favor mycophenolate, especially in minority groups in the United States, but I have no reluctance to use azathioprine as an alternative. If there are side effects with mycophenolate, if somebody's having GI side effects or something like that, I'd switch. The cost is more expensive of mycophenolate, even though it's generic. If somebody wants to get pregnant, even though the FDA says they're equivalent in terms of their risk, they're not equivalent in terms of their risk because the companies that make mycophenolate are saying, tell your patient not to get patient. And there was a risk and modification strategy for mycophenolate. Azathioprine, we have tons of data on people who've had transplants who have had good, healthy kids. So given that, if one of my patients wanted to get pregnant, I'd rather have them on azathioprine. I'd rather have them on nothing, but I'd rather have them azathioprine than mycophenolate. I favor 3 to 4 years of treatment if they're bad proliferative disease because this is what the studies did. And moreover, you're getting them through this crucial period. It's just great for a patient to be able to go 3 or 4 years without having these relapses, having to go back on high-dose steroids, etc. If there are special circumstances, the patient wants to get pregnant and they've done well for a number of years, if they've been having side effects, I don't have any problem with trying to get them off it earlier, but I taper the dose. Membranous we'll talk about in a second, and multi-target therapy I'm going to talk about as well. Now, here we are. We're up to membranous lupus, okay? So you can look at this in a couple of ways. Larry Beck said, how do you tell if somebody has idiopathic membranous? So I'm going to say, well, how do you tell if somebody has lupus membranous and not idiopathic? Looking backwards. So if you're PLA2R positive, you're likely to be idiopathic. But if you're negative, you're likely, you still have a chance of being idiopathic, but it's a smaller chance than not. If you have full house staining means the 3 immunoglobulins and the 2 complement components that we stain for. If you're not a poker player, you don't know what a full house is, but full house is 3 of one kind, 2 of another. The 3 immunoglobulins and the 2 complement components. If you have that, you are likely to have lupus or develop lupus with your membranous. If you have mesangial proliferation, if you have deposits in the mesangium or subendothelial region as well as in the subepithelial, again, it's less likely to be idiopathic. And if you have tubular reticular inclusions in the endothelial cells, if you have those things here, and especially if you're PLA2R negative, and especially if it's in a young female, think, could this be a lupus membranous? So how do we treat lupus membranous? Any one of these things can work. Almost everything has worked in membranous. If you look at this is a study looking at IV cyclophosphamide versus MMF. Jay Radhakrishnan, my partner, put this together. He looked at all the patients in the ARMS trial and all the patients in the Ginsler study and said how many of them had pure membranous. 84 of them did. By coincidence, 42 got MMF, 42 got IV cyclophosphamide. If you look at the results, this is not percent, this is numbers here, that it was the exact same number that had a complete or partial remission, whether they got MMF or cyclophosphamide. So both of them work. There are studies on cyclosporin that shows that it works. There are studies even low dose, just treating with prednisone works. Again, the most important thing in membranous is don't over-treat the patient. Because again, if these patients are going to progress, they're not going to progress rapidly. It's only the ones who have heavier proteinuria, who look like they're getting into trouble with a low albumin, that need big league vigorous therapy. But you could use MMF, you could use cyclophosphamide, you could use calcineurin as well. Now, what about relapses and resistant patients? So this is turning out to be the biggest problem area now because everybody knows how to induce them, and they know if they don't respond to one, you can always consider treating the other. Or there are a lot of patients who can get induced with one of the agents, but they've already had something in the past and didn't like it. They had a couple of courses of IV cyclophosphamide when they were younger, and they don't want to go back on it. So what about rituximab, belimumab, a couple of the other things? We'll talk about them. So this is the LUNAR trial with rituximab. This is the controlled randomized trial that looked at rituximab in patients with proliferative lupus nephritis. The study design looks like it's perfect. Perfect in the sense that it's a blinded control trial. Everybody got the same dose of prednisone. Everybody got the same full dose of mycophenolate. This group got 1,000 milligrams of rituximab, 2 weeks later 1,000, 6 months later 1,000, 1,000. This group got IV normal saline, 2 weeks later IV normal saline, 6 months later IV saline times 2, 2 weeks apart. Well-designed study, but maybe not as well designed as we liked, because there were 144 patients in the whole study. Now, we were told by the statisticians at Genentech that 144 patients was more than enough to show a difference between these groups. It was going to be a definitive study. So what happened? If you look at the 72 patients in each arm, complete and partial remissions at the end of a year. So it was 57 in the rituximab group, 46 in the placebo group. Now remember, the placebo, just like the rituximab group, had a full dose of steroids with taper and a full dose of mycophenolate. There are a number of ways of looking at this and analyzing the data. One, you could say, rituximab was significantly better, but they needed 300 patients, not 142 patients in the study, or 144 patients. If they had more patients, this would be statistically significant. Two, maybe they should have followed the group longer. It would be clearer cut at the end of 2 years instead of 1 year. Three, maybe rituximab doesn't add that much to a full dose of mycophenolate and steroids. Maybe it should only be used for people who are resistant. So again, looking at this, this is not a positive study. Nevertheless, at the end of this study, and with 2 negative studies in lupus already, Explorer 1 and 2, so there are 2 negative lupus trials, not lupus nephritis. Here's a negative lupus nephritis trial. There was an editorial in the best rheumatology journal in the United States, Arthritis and Rheumatism, and the editorial by Joan Merrill was called Rituximab, Wanted Dead or Alive, because no matter how many studies you did on it, people kept using it. Well, they were using it for resistant disease, and it clearly seemed to work. This is a study that was going on in the UK by Liz Lightstone's group. This just shows this is a steroid-sparing study. They only gave steroids the day they gave rituximab. So you got rituximab here in these studies here. You got no steroids in terms of the studies, in terms of, except for that here, steroid-sparing in terms of this. Here's complete and partial remissions. And again, no matter which group you were in, they did about the same. Oops. Here's a study of 300 patients, composite put together from the literature, pool data, mean follow, again, not very long, but again, only a quarter of the patients were non-responders. 40% had a complete response here, and 34% had a partial response. Again, looks pretty good for refractory lupus. So there is a role for rituximab. Exactly what it is not clear, but certainly if you had somebody who's failed the 2 regimens, that would be a drug that would be right up there. Now, one of the things that's been looked at recently is this due to the fact that we're not fully depleting the B cells? Maybe we're getting rid of most of the B cells that are in the peripheral blood, but not getting rid of the B cells in the tissue. Or maybe we're not even getting rid of the ones in the peripheral blood. So this is a study that looked at retrospectively, looking at, did you have any B cells left at all? And here you can see, this is complete peripheral B cell depletion, not 1%, less than 1% or less than 2%, which sometimes the labs report out. This is none doing this, by highly sensitive techniques. If you had a complete peripheral depletion, you had a response rate, a higher percentage of response rate here at 52 and at 78 weeks. And it suggests maybe when we say B cell depletion, we need to actually do more than that. It'd be interesting, since Sean decided to hang around, we can see what he thinks of this study, that in terms of, but should we be reporting not just down to less than 1% or less than 2%, should we be saying an absolute number or something? Benlysta belimumab is FDA approved for lupus. If it's approved for lupus, it's approved for lupus nephritis. So you can use this anytime you want to treat your patients. This is the study 2 studies that led to its approval. Here, you're looking at a systemic lupus responder index. This includes the creatinine, this includes the proteinuria, but it also includes the different lupus indices in terms of have rash and arthritis. It has the serology in it. It's an index. Here you can see this is placebo. This is the response rate with low dose and with high dose belimumab, and the same thing on the other study. Now, you can say, hey, that's great. This is FDA approved for this. These aren't big changes for an expensive drug, monoclonal antibody. So, would I jump to that? No, I have more faith in something like rituximab if somebody has bad disease. On the other hand, if they don't have bad disease, I think this is an option that you could use in terms of these patients, and it's FDA approved. You don't have to fight with them to get the drug. This shows you what has led to some studies that are ongoing now, because in those studies that led to the approval of belimumab, there were a certain number of patients with over a gram of proteinuria. Here you can see those with over a gram of proteinuria who got placebo. Here's low dose and high dose. This is the percentage in remission. Here's the time to remission here, okay, which is less if you got the drug. Both suggest that there is a response in this in people with proteinuria. It's certainly a signal that says more studies should be done, and more studies are being done. Abatacept we've talked about. It's a co-stimulatory blocker here, blocking B7 and CD28. But I can tell you that there are a whole series of negative studies. This is the most recent. I presented this at the ASN last year, that this was, I think it was like 350 patients or so. In any case, if you look at this phase 3 double-blind trial, it's phase 3 in terms of this, because abatacept is FDA approved for rheumatoid arthritis, just like rituximab. Everything is approved for rheumatoid arthritis. Why is everything approved for rheumatoid arthritis? I tell the rheumatologists, all you've got to do is get your patient with rheumatoid arthritis to walk across the room faster, and the FDA approves the drug. I've got to get the creatinine down, the proteinuria down. Those are hard numbers. I can't walk faster. Anyway, you can see complete remissions here that were the same. Sustained remissions were better, but that wasn't the endpoint for the FDA. It was complete remissions. And I would point out that if you look at serology here, the group here that got the abatacept had lower anti-DNA antibody, better C3, better C4, but a whole bunch of drugs have done that. Correcting the serology alone does not necessarily mean that you're going to have a better creatinine and less proteinuria a year later, and certainly it didn't in this study. Now, one thing which is promising is voclosporin. Voclosporin is a calcineurin inhibitor that only have to be given once a day, that they don't usually follow levels on, so it may have a role in replacing TAC or cyclosporin where we are following levels. This is from the published study, which is this year. Brad Rovin is the first author here. Here you can see with complete renal remissions here, here's placebo at 24 and 48 weeks, here's low dose and high dose voclosporin. And these are significantly better. And of course, the next study, this is already published, as we said, the next study is already being done right now and near conclusion. And if indeed it shows the same thing, the FDA will likely approve the drug. You'll have a drug that you can use for lupus. But of course, the one thing I can almost guarantee, how much better is this than cyclosporin or TAC? I can't tell you. Is it going to be more expensive than cyclosporin or TAC? I can guarantee it. Okay, and one more drug I want to mention is anifrolumab. I want to mention this, but not spend a lot of time on it. This is a drug that binds to the interferon receptor. It was studied in 305 patients here. Arthritis and Rheumatism is, again, one of our best journals in terms of this. And when it added to standard of care medicine, that is either IV cyclophosphamide or mycophenolate, you had many more responders by the systemic lupus response, very positive results in terms of this. So what happens? They do the next study. The next study is entirely negative. Here's the initial study showing low dose and high dose. Made a difference here that this is the low interferon people, no difference at all. If you had a high interferon, which the vast majority of lupus patients, high circulating interferon level, blocking the receptor makes a difference. Except the next study didn't show the same thing. It didn't work. Now, that's not published yet as far as I know, but actually I was talking about this in a talk before the American College of Rheumatology meetings last fall, and two people came up to me afterwards and said, we already had a meeting, it's negative, the study is negative. So lupus has been a killer for studies. And that's why when we've got a positive vocalosporin study, even if it's just a little bit better and drops proteinuria, it's still worthwhile. Now, one other thing, though, that has had positive results, and it's here you can use, is multi-targeted therapy. This is a study that looked at mycophenolate, tacrolimus, and steroids together versus IV cyclophosphamide and steroids for induction. And this study showed a significant benefit in a group of people, a very large number of Chinese patients here who had active lupus nephritis. So you look at this and you say, wait a minute, here's at the end of 6 months, this is clearly, the p-value is very high, it's a robust number of patients and everything, maybe we should be using this in everybody. So here's the problem with this study. Now, you can always tell how good a study is by looking at where it's published. So this is published in the Annals of Internal Medicine, which is a very good internal medicine journal, but let's face it, for a nephrologist, it's not Kidney International, it's not JASN, it's not CJASN. If you're a rheumatologist, it's not Arthritis and Rheumatism or, the Annals of Rheumatology, one of their best journals. So why is it in the Annals of Internal Medicine? Because every time somebody, or it could have been in the New England Journal, but it wasn't. The reason is that every time the reviewers looked at this, they said, now wait a minute, what do you mean by a remission here in terms of this, the overall response? Well, one of the major things was decrease in proteinuria, but you've got TAC in this regimen. A calcineurin inhibitor always decreases the proteinuria. The question is, if it decreases the proteinuria, is there going to be better renal function 3 years later, 5 years later? And they couldn't say this from this shorter study. So promising, but again, it could be the major thing is reduction in proteinuria. Now, that may be good if your patient has 5 grams of proteinuria at the end of 6 months, but on the other hand, it may not be so good if it doesn't make a difference in terms of long-term outcome. They do have some data during a maintenance phase now. Here's TAC, mycophenolate, and steroids here versus azathioprine and steroids, and you can see the probability here without relapse is about the same between these two groups. So they have good maintenance data here. Here's the GFR. This is complete remission. Here's the creatinine, and here's the GFR. They're all about the same. So this certainly is something you could add on to your patient using a calcineurin inhibitor if you have them on mycophenolate and steroids, or if they're on azathioprine, you could add on, again, the calcineurin inhibitor to decrease the proteinuria and presumably get a better remission long term. So back to our patient, what induction therapy? Mycophenolate or IV cyclophosphamide. There's good data on both short-term and relative long-term, not 20 years, but fairly long. If she were white or black, I'd probably start the same thing. I would use the same induction therapy. I wouldn't use racial factors because there's data on both now. I prefer mycophenolate maintenance, but if somebody said they wanted to use azathioprine for specific reasons, no problem. What if she had extensive crescents? I'd have to treat very vigorously, and again, the outcome is not great. If she had tubulointerstitial fibrosis, the outcome is even worse. Aggressive therapy for the crescents, then again, and the TIF, the tubulointerstitial fibrosis, the more likely I am to pull out. Maintenance therapy, MMF or azathioprine, and again, looking at relatively, especially for younger people, looking at 3 to 4 years, unless they have a reason to come off, getting them that time where they don't have relapses, they're not on high doses of steroids, they're not cushingoid, they'll finish their schooling, they'll get engaged and married, and whatever this is, again, this is 90% young females here, that just giving them that time, not in the hospital, is terrific. At that point, coming down slowly, it's just got a very good track record. And if the patient fails or relapses during these therapies, rituximab looks like a good first line here, especially as we're getting more and more data in, in ANCA-positive disease and membranous nephropathy. Belimumab can be used. Again, no reason not to. It's FDA approved. Others, ACTH, calcineurin inhibitors, we'll see. We'll see what the role is. The big thing is we have many options now. One size does not fit all for lupus anymore. The induction and maintenance look pretty clear, but the relapses, there's a lot of things, and there's a lot of other things being studied. And I'll stop here. Thank you.